Welcome to Connect Over Coffee, where we host candid conversations, make meaningful connections, and talk about all things ovarian and gynecologic cancers. I'm Runsi, the founder of Ovarcome, and today we are joined by a world-renowned gynecologic oncologist, Dr. Robert Coleman. Dr. Coleman is also our advisory board member, and he's sitting down with us for a long-form conversation on this podcast to talk about all things ovarian and gynecologic cancers in honor of Ovarian Cancer Awareness Month, as well as Gynecologic Cancers Awareness Month. Dr. Coleman, welcome to this episode. It's been a while.
Yeah, well, thank you so much for having me. That's great to be here.
Fantastic. So I want to talk about, since we are about to start the Gynecologic Awareness, Cancers Awareness Month, want to set the stage with our discussion with you on not just ovarian, but different types of gynecologic cancer. So before we get into the discussion, tell us very briefly, what are the different types of gynecologic cancers, and more specifically, what are the different types of ovarian cancers that we should know of?
Sure. So we can start right there. So we classify gynecologic cancer as those that arise from the female genital tract. So that would include vulva, vagina, cervix, endometrium or uterine, and then ovaries with fallopian tubes. That's kind of the unique aspect of the specialty. In some parts of the world, breast cancers are also included in that. But as you know, breast cancer is not uniquely female. And but in the United States, we focus pretty much on as what I just mentioned, female genital tract. Each of these areas are lined with tissues that can become malignant. So most commonly, we talk about the surface tissue. So like for vulva and vagina and cervical, that'd be like the squamous tissue, the external surface. And then on the inside of these organs are the epithelium, which can be things like the glandular components of the cervix, the glandular components of the uterus, glandular components of the fallopian tubes, and those that can arise in the ovarian surface. We also have supporting structures for each of these tissues. So what we call the stroma. And the stroma is made up of a whole bunch of different cells that can also be a source for rising malignancy. And of course, these are much more uncommon. But the things like lymphatics, vasculature, and the stroma itself, the actual fibrous tissue, can all be a source of malignant transformation. So, but most of what we're talking about today, and in the common types of tumors that we deal with, are those that arise from the epithelium or the surface. And as we've learned more and more about diseases like ovarian cancer, we've learned that the single point of origin is still somewhat elusive. We've talked a lot about in the past about how the fallopian tube can contribute to this because of its proximity and the number of hormonal microenvironment, as well as genetic changes that can lead to this malignant transformation. But we do know that cells within the ovary itself, such as the germ cells and stroma cells, as I mentioned before, can also be a source of a type of ovarian cancer. So as you mentioned, it's nice when you say that somebody has ovarian cancer, it's nice to have a little more detail as to exactly what are we talking about, because these cancers that can arise from within the ovary or the para-ovarian tissues can all be a separate kind of tumor and may have a separate type of treatment pathway. So those are all really, really relevant.
So when we talk about the different types of ovarian cancers, what are the types that we are looking for, other than the low grade and the high grade serous? That's a broad category, but within each of those, what are the main ones that we should know of?
The histology itself for epithelial tumors run in the range of the cells that are native to the fallopian tubes, as you mentioned, the serous tumors. But we do see transformation from different cell types, such as clear cell, endometrioid, mucinous. There's a cell type called transitional cell, which is similar to what we see in the bladder. and that's another histotype that can be that can occur. I think I mentioned mucinous is another rare subtype that we can see. so so this differentiation can go down a number of different lines, but of the epithelial ovarian cancer, that's kind of I usually call them like they're like flavors of ice cream. So you got vanilla, which is the serious, and you've got all the other flavors. So that's the kind of the spectrum of the diseases that we see.
Thank you. And so within the different types of gynecologic cancers you just talked about,
Mhm,
we understand that ovarian cancer is already quite rare.
mhm,
So between the endometrial, ovarian, then vulvar and cervical and other
mhm.
cancers, if you had to order them in the order of rarity, for the lack of a better word,
Yeah.
how would you do that?
Well, it's good. Yeah, I'm glad you brought this up because there is a little bit of a misconception between what we as clinicians call rare and what the FDA considers rare. Um, Generally, what we're talking about are incident cases per year. So, how many new cases are diagnosed? And by far, depending on how you define cervical cancer, if you include the carcinoma in situ, that would be by far the most common. But invasive cervix cancer is actually the least common of the big three, which would be endometrial first, ovary second, and then cervical. Then, of course, much rarer than that would be primary vaginal and vulva cancers. They're much less common. But even within those categories, for instance, mucinous cancer of the ovary is really uncommon, but it's not necessarily so uncommon as it arises in the cervix. So it's a little bit of we can play this game a little different ways. But the reason I wanted to emphasize this issue about incident is that that's not what we see in the clinic. So when people say, well, how often do you see X disease? That's a measure of what we call disease prevalence. So incidence are the number of new cases that are diagnosed in a year. The prevalence is the number of patients in any one time that actually have the cancer. And so what we found, like in ovarian cancer, where we see just under 20,000 incident cases,
Mhm.
we now have about 250,000 prevalent cases in 2026. So there's a big gap between incidence and prevalence, and a lot of that has to do with the development of new therapies and better strategies for caring for patients.
And thank you. We are going to jump right into all the new therapies that we are so excited about. So, I was, while writing up this questionnaire for you, I was thinking that, we still define platinum resistant ovarian cancer by, the clinical time cutoff, 6 months, therapy progression, etc., the window.
Mhm,
But we know that in 2026, with all the folate receptor alphas coming in, the ADCs, the glucocorticoid receptors, immunotherapy combinations now entering the space, should we still be thinking of platinum resistance as just a one disease state, or should we move
mhm.
towards, something more well defined by target expression, by phenotype, DNA repair status, and just the general, environment, microenvironment? So tell us a little more about that.
I love it. This is like a favorite topic to discuss because we've talked about this over the years. Yeah. So one thing I think probably the viewers should appreciate is that platinum sensitivity is a very plastic condition. We see it evolve, it can change, it can be reintroduced. Nevertheless, the reason we focus on platinum is that platinum has been our most active single agent. So we always try to maximize the opportunity to use the agent across this disease spectrum. And in all three of those major diseases, we use platinum-based therapy, actually, including with any of the radiation that we use as well. So platinum is a very important drug to consider as far as the therapy. We use the term platinum resistance and platinum refractory to describe a phenotype that's related to the experience of the most proximal treatment related to platinum.
Mhm.
So outside of direct progression while you're taking the drug, it becomes a very much, as you just mentioned, as a spectrum of whether or not platinum can be either considered as a reinduction therapy, as the next line of therapy,
Mm.
or are we removing it completely? And the answer is that we don't ever really remove it completely, because we know that certain drug combinations can actually sensitize these cells back to be sensitive, back to be potentially responsive to platinum.
Mm.
And so but our difficulty is that we don't have a real time functional assay to say this tumor still has platinum sensitivity, this tumor doesn't.
Mm.
And and if we were going to be, precise about this, we'd have to test at every single time we switch therapy to know whether or not that phenotype of platinum sensitivity, has returned,
Yeah.
or could be leveraged.
Thank you. So, just staying on this for a little bit, we know that the platinum-resistant landscape has changed and evolved very, quickly. So, MIRV is now approved, and then we talked about the Rosella trial also being approved in March for certain patients, and a few others, including the Keynote B96, right? So, with all these new treatments coming in, how would you now build a rational sequencing algorithm for the patients, and especially when the patients are eligible for more than one approach? How would you? What are the changes that are coming in terms of, sequencing with all these?
Yeah, yeah. Unfortunately, the question of sequencing, was on our plate many years before these drugs became available, and we've still not answered it.
Okay.
The problem is that when you think about sequencing, you're like outlining several strategies for treatment based on a point in time early on. And if you were, let's say, a patient who was dealing with platinum-resistant ovarian cancer in 2022, and you were on a therapy that allowed you to stay in the kind of the treatment landscape when MIRV became available, that would have changed your treatment strategy that you mapped out in 2022 because you didn't have it at that time. So you can see how it evolves. And so when we talk about strategy, it's very difficult to talk about more than just like the next line. And we've done a few trials where we say, okay, if you get this drug at this point in time, or we're going to treat you with this drug, the next line of therapy, and everybody's going to get that specific sequence versus, let's say, the opposite. And even those types of trials, as simple as that sounds, those types of trials are very difficult because some patients who started on one therapy don't make it, or aren't eligible for the sequence. So it's a very difficult clinical scenario that we put ourselves into. But I always say that, the longer you live, the longer you live. And so hopefully, as new therapies become available, we'll be able to leverage them just like we did with MIRV or with B96 or Rosella or even bevacizumab. So, but you ask an important question about how do we pick if we have, let's say we have a patient who's actually eligible for all of those agents.
Exactly.
How do we pick? Well, the clinic, we don't have any direct comparative trials, at least not yet, that would say, okay, is MIRV better than, say, weekly paclitaxel and pembrolizumab, or is weekly paclitaxel pembrolizumab better than nab-paclitaxel and relacorilant, or is single agent liposomal doxorubicin better than weekly paclitaxel and bevacizumab. So there's all of these things that come up there. So generally what we do is we look at the available data and we try to match the patient characteristics to those trials so that we can at least have some foundational expectation about where a specific patient might either respond or not respond. But even that, even that very straightforward strategy that we use in the clinic every single day is taking data that we're generating from a population of patients, a population of women who have this disease, and we are applying our patient to that population, which may or may not be representative. If you can think of the typical bell-shaped curve, the median, which is the middle of the curve, represents one specific observation. But what we don't know is whether or not your patient is over here, or are they over here in terms of that distribution, right? So the application at the patient level is difficult to do looking at population-based data, but it's the best we have. And it kind of gets me back to that point that I think I mentioned before, which is that as time goes on, our hope is that we'll be able to develop very patient-specific characteristics that can be leveraged for specific types of tumors. And so, and we've already seen this in some cases. Mirvetuximab, for instance, is approved for patients who have FR alpha expressing recurrent ovarian cancer. We don't know whether or not that would necessarily be better than something that's open to a broader population like nab-paclitaxel relacorilant. But we would look at those characteristics to see whether or not the antecedent toxicities, the experience with the previous line of therapy, any other comorbidities, the tolerance of medication, the schedule, all of those things become part of the nuance or the art of medicine to identify what might be the best at that point in time.
And thank you so much for clarifying and describing the process, because that makes us understand how difficult, like you said, it's not easy to determine which treatment path is best for the patient yet. Well, we're going to go there, but not yet. And also, I think I was just thinking as you were speaking, that sometimes it can be also the access issues, right?
Yeah.
I mean, that the patient may not even have, like, depending on where she lives in this world, not all of these drugs are available to her even. So by default, some of these will not be an option.
Correct.
So,
And schedule is one of those. So like I said, you mentioned B96 and Rosella. These are two trials that are looking at a foundational treatment based on weekly paclitaxel. Well, some patients can't make that weekly trip.
right.
It's just impossible. And so, and so you're right. Those are the other intangible factors that can occur.
Okay, thank you. So, you talked about the folate receptor alpha testing, but tell us a little more about the testing, like the folate receptor alpha testing in particular, and antibody drug conjugates in general. And so, from a trialist's perspective, I always have two questions within my one question. So
yeah, exactly. Which is why I answer with 3 responses.
Exactly. So, from your perspective, from a clinical trialist perspective, what do we still need to learn about when to test, which tissue to test, and whether folate receptor alpha expression should be treated as a fixed biomarker or a dynamic one?
So it's a great question. And, I think the listeners might be surprised to know that targeting the folate metabolism was one of the very first strategies that was used to treat cancer. In fact, our first successful cure actually targeted folate metabolism in patients who had gestational trophoblastic disease back in the 1950s. So folate's been around a long time. We've known it's been a critical source for development. What we learned in those subsequent 60, 70 years was that there are multiple different types of folate receptors and different points of folate metabolism. And there have been multitudes of drugs that have been developed that are targeting this specific pathway, and many of which are still in use today, such as methotrexate. So it's been around a long, long time. What we learned about folate receptor alpha, which is a surface receptor we find on a lot of solid tumors, has a different role in specifically as it relates to folate metabolism. So it's a different kind of pathway, but it was targetable. And about 6, 7 years ago, we started to leverage this with what we call an antigen targeted drug, which was actually using a folate-like molecule to go into this folate receptor, to bind to it, and then go into the cell and release its payload. We had some early signal that might work, but in the phase 3 trial, it showed up that it didn't. It wasn't efficacious more than chemotherapy, so that program kind of died down. But it did highlight the fact that we could leverage this idea of surface expression to the development of cytotoxic therapy. And that's where this antibody drug conjugate, so as you know, you got an antigen, which is like my hand, and you have an antibody, and they come together like this. And that's how metabolomics work in the cancer cell. What we found is that the folate receptor alpha could be targeted with an antibody that would then be brought into the cell. Well, the antibody drug conjugate strategy is also been around a long time. Most people might not remember that over 100 years ago, the concept of a stealth molecule was actually being developed by a Nobel laureate with the idea that it could be used to treat infection. And this was Paul Ehrlich back in the turn of the last century, or the century before last. But this was then rapidly adopted to maybe take advantage of it in the antibody drug conjugate, which is three components: an antibody that targets the specific antigen, a drug that's attached to the antibody that's used as a cytotoxic, and then a linker, which allows the compound to circulate in the bloodstream stably and then reach its point of target, be ingested by the cell, and then release the drug. So with that comes a number of challenges. So one is how can you design a stable molecule that doesn't prematurely release the drug? Well, the reason these drugs are actually attached to an antibody through this linker mechanism is that the drugs themselves are too toxic to deliver intravenously nakedly. So so the idea here was that we could, if we linked it to this molecule, that it could stay stable in the circulation and get to where it was trying to get to, where it could then be released and do its damage. So this concept is what mirvetuximab is, as you mentioned, and it's been approved. It's folate receptor alpha targeted, and it carries what we call a tubulin poison that is attached by a linker, which keeps it stable in circulation. And this was the first of these ADCs in ovarian cancer to show a benefit in overall survival. So that's how it got to be where it got to be. But it took a lot of effort, a lot of effort to get it there.
Absolutely. Yeah.
So let me answer your other question about the stability of the target. So we are learning more and more about the dynamics of surface antigens and targets, as you mentioned. We think that the folate receptor alpha, being a critical component of cellular metabolism, is probably pretty stable.
Mhm.
We don't have a lot of serial data to say that it's expressed at the same level. But you mentioned, and we've talked about this on this program before, is that individual cancer, cancer cell populations do have a heterogeneous expression of targets. So in my practice, if I get a negative result and I have an opportunity to use this drug in a quote under its label as a platinum resistant phenotype, I'll resample in hope that I get a different result. However, if I get one that's positive in the past, I'm going to keep it there so I can potentially use the drug. The reason I say that is that the relationship between the density of expression on the surface of the cell and the efficacy of the drug is not so linear. So we have seen actually in another drug called trastuzumab deruxtecan in breast cancer that even very low expression of HER2 was still led to responses with the drug. So so we're still sorting that out, and I'm sure we'll talk about this, but the new drugs that are coming into the space are starting to evaluate whether or not efficacy can be leveraged can be expected in lower expressing tumors. Mirv right now is mostly targeted towards these high expressing tumors, although in combination with bevacizumab can be given at lower levels.
Thank you. And this I'm staying on ADCs because it's such a hot topic. So it's becoming more and more important in gynecologic cancers. So what are the resistance mechanisms that we
Yeah.
be watching for more closely, and should the next generation trials be designed around ADC sequencing or ADC combinations, in your opinion?
Good. That was two questions. So you
Of
cut
course.
yourself.
That's how
So
I roll, Dr. Coleman.
I love it. I love doing these. You're such a good person. So resistance mechanisms to ADCs, I think we're still learning them. But if you can imagine the natural biology of how an ADC works, as I just expressed. So surface expression. So that's one way of resistance, is that the expression is gone. You can have the interaction between the antibody and the receptor itself be imperfect or blunted. Once it's inside the cell, the releasing mechanism, which requires a interaction between the cell's lysosomes. So those are the scissors that are inside the cell that will cut the linker and allow the free drug to be available to do its thing in the cell. The cell itself has mechanisms to protect itself against these toxins, such as the PGP pump. So these are substrates for this pump that says, "Hey, I have a toxin in the cell. Get rid of it." So that can be a substrate for the PGP pump, among other resistance mechanisms. And then the drug itself. So as I mentioned, that we have two major classes that we use in GYN. One is a tubulin poison. So it's targeting a specific element in the process for DNA separation and division. And the other is a topoisomerase inhibitor, which is another pathway that's involved with DNA replication. So there's two different main targets. Each of those targets have different resistance mechanisms in and of themselves. So one of the mechanisms for resistance for these tubulin targeted drugs like mirvetuximab is a mutation in the tubulin proteins themselves. So we don't see that they have the same efficacy as we might expect. And for topoisomerase inhibitors, we've learned from the many years of using topoisomerase inhibitors such as topotecan and camptothecin that the expression of the target if within the DNA, the topoisomerase 1 target itself can be down or can be repressed or deregulated so that it's no longer a substrate for the tubulin poison or for the poison itself against the topo1 enzyme. So there are more. That's just of the cell. The tumor microenvironment can also be responsible for it. We've seen this with just chemotherapy in general, in that the stroma itself can be hostile to distribution of these chemicals into the tumor microenvironment. And of course, you have always hanging around the immunotherapy potential aspect of this, where different components of the cell and the immune microenvironment don't allow these cells to be vulnerable. So all those are focus of next generation, including a new generation of agents that are antibody-like but not antibodies. And these antibody-like drug conjugates are being developed right now with multiple different targets. So you can put more than one chemotherapy. You can put a chemotherapy and a imaging agent. You can put an antibody on top of a targeting drug. So there's a lot of innovation coming with this kind of platform.
What is the rationale behind antibody-like but not antibody? I'm just curious.
So the antibodies themselves do have, specific, they have to interact with the antigen in a specific way. Some of them are very high affinity and some of them are not. A drug like trastuzumab, requires that the receptors actually bind together. So there's a dynamic process for which that leads to activation. So the actual antibody has to interfere with that dimerization. So what these new platform drugs do, they have better penetration into the tumor microenvironment, and they're not dependent on surface expression. And they have the capability of delivering multiple warheads of different types. Like I mentioned, they could be delivering radiation and chemotherapy in the same molecule.
Yeah. Okay. Thank you. So you were a lead investigator in Ariel 3. So since then, the field has had to, there's a more complex benefit risk structure when it comes to PARP inhibitors, and then there's certain recurrence settings, and there was also withdrawals and narrowed usage. And so what did the PARP era teach us about the difference between progression-free survival, overall survival, biomarker selection, and just overall long-term toxicity with all the developments that have happened around PARP since inception?
Yeah, thank you for that question. I think that, let me start with just what the PARP era brought to us. Prior to our experience in the recurrent ovarian cancer domain, among biomarker positive positive identified tumors, in this case, BRCA1 and 2 mutated tumors. We had never seen a hazard ratio as low as we saw in Solo 2 and in Solo 1, which were phase 3 trials against standard of care agent of observation as a maintenance strategy in patients whose tumors were identified as BRCA1 and BRCA2. We linked the biomarker to the specific action of the drug.
Mhm.
And before that period of time, we really had not had that before, nor could we expect to see changes in progression-free and in some cases overall survival to the magnitude that we saw in that era. It was like we just saw on pancreatic cancer at ASCO. It
Yeah.
was a drop the mic moment.
Mhm.
So that was the first. The second thing we learned in the PARP era is that we spread it like peanut butter. So we put it in every situation that we could think of. And I think that the way that we designed our trials in that standpoint overshadowed the fact that tumors themselves can be one characteristic or the other, but they can't be the same characteristic at the same time. And so that led to, I think, some ambiguity in the interpretation of our subsequent trials after we had this massive win. It did lead to a number of approvals, as you mentioned, not only in the treatment setting, so using it as a treatment for these patients, but it was also beneficial in delaying progression, both in the second line platinum sensitive era and in the frontline era. But as I mentioned, the way the trials were designed, it was confusing as to exactly who was benefiting and who wasn't benefiting because we didn't do the trials, I think, in a selective enough way to sort out that signal. Because of that, many patients who probably didn't receive any benefit from the PARP inhibitors in this process were treated. And when we looked at long-term follow-up, the overall survival endpoints, we started to see that we were either losing the efficacy signal, or in some cases, it looked like the potential efficacy signal went in the opposite direction.
Mhm.
Now, it's very suggestive. It's not, we never really actually proved this is the case, but it did grab the attention of the regulatory authorities, the FDA. And they said, listen, until we get more information about the safety, because of their mandate, the
Right.
safety of using PARPs in this all-comer kind of indication, we're going to retract these or restrict these labels to the places that we know it's actually efficacious. And that's why it sits where it is today. So we learned a lot through this process. For me, I actually feel like this was a good move because I do feel that we did overstate our case a bit. But what we've learned in the process is that we may have pulled back the covers too much, and so we haven't. I think that there are patients that potentially could benefit from these drugs, but are not eligible to get it anymore, particularly in the recurrent setting. But we'll again have to work through that so that we can provide the right audience for these drugs.
I'm going to stay on this for a second, Dr. Coleman, because I know that you are the expert when it comes to the PARP inhibitors. Because we do get a lot of questions from our overcomers exactly on the points that you mentioned. That
Mhm.
like there is now this almost a mandate that beyond 2 years you need to get out of the PARP regimen, right?
Mhm.
So
Mhm.
that's the number one question that we receive from so many of our overcomers, that I'm doing so well on PARP and I feel uneasy to get off of this regimen, because what if the cancer returns, and why
Mhm.
do I have to get off? That's one of the things. And then secondly, the other question that we consistently receive is, what is the, if not 2 years, then, there are patients who have been on PARP for like 6, 10, 8, number of years, right? And they're
Mhm.
fine. So how do we reconcile all of that with the new set of expectations that have come in, that which is more rigid, that you have to get off after 2 years? Are there any patients in your own practice or otherwise that you have seen that actually could benefit beyond the 2 years that we are missing the mark on by just following, rigidly the new rules?
Mhm. Um, I think So there's a couple components to this question I think that are important for our overcomers out there. One is that the absence of progression while on maintenance therapy does not mean that the drug is working.
Okay.
One number one to consider. Number two is that constant exposure to the drug could potentially have negative impact on subsequent treatment. And the third is that if you critically look at the data that we have to date, I think there's fairly strong evidence that we're probably treating patients too long with these drugs, even if they carry a BRCA1/2 mutation. And the last thing I'll mention is that there is a risk for secondary malignancy,
Mm.
such as AML, leukemia, in myeloid leukemias in patients who actually carry the mutation, the ones that are most likely to be beneficial and get it early on in the treatment course. So in our practices, we do have patients with recurrent disease who have been on PARP inhibitors for a long time, because in that setting, we didn't have an upper limit. We just treated to progression. In general, we got about 2 years, but of benefit out of that situation when we look at progression-free survival in the most sensitive cases. But many of these patients now are identified in the frontline setting, and they're getting exposure to PARP as a primary maintenance in the frontline in that frontline setting. So they wouldn't really be candidates for retreatment. But I do think that those kinds of considerations are extremely important. I mentioned that in Solo 1, which is probably the purest trial that we have, was the evaluation of patients who had tumors or carried a germline mutation in BRCA1 and BRCA1 and BRCA2, and had responded to or didn't progress on induction chemotherapy. So those are two important variables. And those patients were randomized 2-to-1 to olaparib, the PARP inhibitor, versus placebo. So in this particular trial, when we monitored what happened to that patient cohort over time, we saw that there was a clear separation in the probability of a recurrence between the placebo arm and the experimental arm with olaparib. But after about 12 to 15 months of either observation or treatment, the curves themselves actually seem to parallel each other.
Mm.
So when we looked at, and we did this experiment in endometrial cancer, if you looked at patients who, for instance, did not have a progression by 15 months, you couldn't tell if there was a benefit between that patient population and the control population from that point forward. So the question is, did we need to do it? And that now then formulated the hypothesis for a current trial, which is enrolling well, which is looking at 1 year versus 2 years to prove whether or not this hypothesis is the case. So I clearly appreciate the dependency component of this. In other words, we depend on something to kind of tamp down this disease, but it doesn't come without a cost. And so we need to be very careful in understanding the true rationale for long-term treatment, because we know that it can induce resistance, induce potentially secondary malignancies in patients that are otherwise cured, and may not be of any benefit other than toxicity.
Okay. Before I move on to the next question, I'm going to ask you this because anytime we have talked about progression-free survival and overall survival, not with you, but other physicians on this podcast, they have always talked about Dr. Coleman and his hazard ratio. So all of them, I'm not even joking. So tell us, the importance of hazard ratio versus when it comes to, because they repeatedly tell me and tell the audience that Dr. Coleman always says, look at the hazard ratio, not the progression or the overall survival. So tell us more about that, because
Okay.
we have,
All right.
yeah.
I'll put it in some context. So as I mentioned before, we talked about the bell-shaped curve, right? When we report out these data on clinical trials, we're taking a population of patients at the beginning of treatment, and then we monitor what happens over time. And then we pick a middle point to say that this is kind of where the middle or the average benefit existed with respect to lack of progression, which is fine when you talk about a population. But at the patient level, think about if you were diagnosed today and you were given this treatment, and you were told that it should keep your treatment free on average about 15 months, how precise is that statistic for you today when you've not even received a single cycle of treatment?
Mm.
Okay, so then let's go 1 month later. Okay, you went 1 month later, you didn't have a progression event. So what's the likelihood that you're going to progress at the next CAT scan or the scan after that?
Yeah.
So what I'm trying to do, and the reason I emphasize this is that when a patient is sitting in front of you and they're thinking about what's their future, it's not informed by anything that you've heard about in the past. It's just a ballpark. And so what we can tell if this trial is done appropriately and it meets this concept of proportional hazards, what the hazard ratio is telling you is what is the probability of an event at the next assessment. So rather than saying, well, I have a 50% chance of being without progression in 15 months, this actually tells you that your probability of progressing at any point before or after that 15-month mark is, let's say, 50%.
Mm-hmm.
Okay. So at the patient level, the only thing that that patient is concerned about is whether or not the next time they're evaluated is the tumor didn't progress or didn't come back. That's not going to be informed by this median, which is in the middle of some time point down the road and applies to this general population. And so I think the only way that to describe that is in terms of these probability reductions. And you can see it very clearly in some of these studies. When you look before the median and you see that, let's say at 3 months, the proportion of patients who had a progression event, let's say was 80%, or excuse me, 20% in the experimental arm, but it was 40% in the control arm. So there was a protection of progression for the patients that were on treatment up to that point in time by 50%.
Yeah.
50% reduction. It has nothing to do with the median. It has to do with what is your likelihood of making it through the next assessment. So yeah, I do harp a lot on this because I do think that when people see, the curves themselves can be very not, they can be very not conformal. They can bounce around and they can say, hey, listen, the median is only 6 weeks different, but the tails of the curves have split so that if you look at a time point, let's say at 3 years, there's twice as many patients alive as opposed to the control arm, but at the median, there was only 6 weeks difference. That we see. So, so I think that the median is an easy soundbite, but it doesn't help us in terms of how to counsel patients.
Thank you so much for that description because, it's important for us and the patient community to understand the difference between the hazard ratio and the progression and the overall survival. And this was clear enough for all of us to understand. So thank you.
Sure thing. You bet.
Yeah. And then let's talk about biomarkers because there's a lot of them right now. And do you feel like the biomarkers that we have now are good enough? And of course, I know your answer, but I'm just going to ask you anyway. And can you also tell us about all the biomarkers that we are using now, the ones that are emerging, and how are we doing when it comes to testing for biomarkers in general for gynecologic cancers and the gaps that we see?
Sure. So what I'll say is that I'll answer the second question first because there's always two. And I never get to the second question, but let me answer that one first. We're doing a much better job of getting comprehensive testing, I think, as earlier and earlier in the treatment sequence. It's becoming the norm now to get comprehensive testing, and frequently testing companies are providing a whole menu of options that we're getting that are relevant for clinical practice. So I do think that that is increasing. Having said that, it's not enough. We do see very tremendous discrepancy in testing rates across the country in different types of practices, in different locales, in different resource settings. So there's a definite need to standardize that. But let me start with another concept for our overcomers. Biomarkers come in many different flavors. The ones that we use most commonly when we talk about biomarkers are prognostic and predictive. Now, the terms sound kind of the same, but they have very, very different meanings. And some biomarkers carry both prognostic and predictive capabilities. The multitude, the vast majority of biomarkers that we talk about in patients with gynecologic cancers are prognostic, meaning that they're not tied to any specific response to an agent. They're just generally describing the natural history in the presence or absence of the biomarker. Let me give you an example. In almost all of our tumors, we stage patients. So staged, as you can imagine, stage 3, 4 has a different natural history than stage 1. Well, stage is prognostic biomarker, right? So it tells us something about the natural history of the disease. We know, for instance, p53 mutation has, if the tumor has a p53 mutation, it has a different biology than if it's wild type. These are prognostic biomarkers. A patient has surgery for ovarian cancer. If they get all the tumor out, that complete gross resection variable is a prognostic biomarker against the patients that can't get surgery at all, for instance. Okay, so these are not linked to specific drugs or specific treatment. They're linked to the natural history of the disease, positive or negative, based on that biomarker. Predictive biomarkers, there are precious few of these. As we talked about with mirvetuximab, that appears to be a predictive biomarker for mirvetuximab, meaning that in patients whose tumors express a lot of that biomarker, they have response, and patients that don't express it don't necessarily have a response. But the population of patients who have FR alpha high or low basically do the same with general therapy. So it doesn't have prognostic significance, but it has predictive significance. And let me give you one more just to be confusing, because we talked about it already, which is BRCA1 and 2 mutation. So BRCA1 or 2 mutation, we've known for years, has prognostic value. We've learned that with treatment of like platinum-based agents, these patients tend to have longer and more durable responses than patients treated with platinum that don't have this specific mutation. So it has prognostic implication. But because the PARP inhibitors, which we just talked about, are directly linked to the efficacy of the drug in the patients that carry the mutation, such as SOLO1, which showed that those patients who carry the same biomarker, they both had BRCA mutations. If they got the drug, they did better than if they didn't get the drug. So it has a prognostic value and it has a predictive value for PARP inhibitors. So yes, we have a multitude of prognostic biomarkers. Many times these prognostic biomarkers relate to each other. So for instance, stage, as I mentioned before, and the probability for a complete gross resection can be linked. They can be, they're co-variables. And so when we do these studies and we develop prognostic biomarkers, we don't often account for all these different nuances that can occur in the same tumor. So we can't really sort out whether or not they really carry a true predictive value. On the other hand, these other agents, as we've been talking about, like specifically ADCs, PARP inhibitors, immunotherapy, these types of drugs can be linked to specific predictive biomarkers, and as such, many times the indication for the compound is related to a predictive, or what we call companion diagnostic.